hardware and the devices have improved over the time and we started doing more complex cases, we come across some complications of device dislodgement. So I'll be talking to you about some case studies here. This was first case about the side wire, 49 years old male, came with anti-wall MI post-infarct angina. LED was a proximal 90% with a large diagonal. Initial plan was provisional stenting. We took a 3 by 38 days, deployed in a proximal to mid LED. Result was good, but the diagonal got pinched and the flow was reduced. So when we tried to remove the wire, we saw that the wire is broken, the black part is not come out. So we took and the patient had a severe chest pain, ST elevations, so took a different wire, crossed the diagonal, then dilated the diagonal, and we had to stent it. Diagonal flow established. So what about the fragment which is broken? We tried to put a snare, tried to remove it, but we couldn't catch it and remove it. So when we took a shoot, we thought that it's in the ostial LAD and it's there in the LAD only. So we took a 3.5 18 millimeter stent, placed it at ostial LAD to proximal part and covered the broken part, and that's how we got a good result and the patient was stable. And now almost 3 years patient is doing well. So this is how we tried snare, but that couldn't succeed. So we went ahead with a second stent and covered the wire. Second case is about the balloon rupture. Again, 44-year-old male came with anti-wall MI. Patient was thrombolized post-infarct angina. Patient came for angio, and you can see a 99% proximal lesion for artery around 4 millimeter size. After putting a 4 by 18 stent, we saw that the proximal lesion was not very well. Stent expansion was not good. So we took a 4 by 12 NC balloon, and you can see when we inflated the balloon, there is something popping out in the proximal part. That balloon, I think the distal where the attachment was there was not good or what, but balloon got ruptured there. And patient had a thrombosis in the LED got occluded. We removed the shaft of the balloon, and what we saw that everything had come out, but proximal part, there was some part which was remaining inside the LED. So we wired LED circ, tried to dilate the pre-dilatation by 4 by 12. We could get the flow across the LED. And we did a IVUS which showed that there is a proximal, some fragment of the balloon remaining inside, and which was there in the LED inside only. I don't have a IVUS run here. So what we said, we'll go with a 4 by 18 stent, and we deployed the stent and covered that balloon part and got the good result, and the patient got stabilized. Almost 2 years now patient is doing well. When balloon ruptures, I think that we are worried about air embolization, dissection, perforation, subintimal hematoma, fragment which is broken, what it will do, and the IVUS helped us in finding out where to place the stent, and we could bail out the patient. Again, the cause of balloon rupture, high pressure dilatation, fibrotic lesion or a calcium spur causing the rupture of the balloon, or a quality problem, because what we saw, there was a proximal inflation proximal to the markers also. Again, the third case is about the broken balloon, 59 years old male, STT changes, borderline LV hypertrophy. LED was around 80% and RCA was normal. Circ OM lesion was there. We put a LED diagonal wiring, put a stent in the LED diagonal, but while removing the diagonal balloon, we saw that the balloon was broken. And we tried to locate that where the fragment is and where we'll be able to catch with the 3 by 12 balloon inflated in the catheter. We tried that, but that we couldn't catch it properly. So when we checked it properly, so balloon broken fragment was seen in the subclavian, and there we took a snare and catch this the fragmented balloon shaft, and that with that we could remove the balloon properly. This was the snare which catch hold of the, and we could remove it through the sheath. And then again we rewired the LED and completed the procedure. Kissing of the LED diagonal, and that was completed. Forceful pressure on balloon needs to be avoided. While recrossing the side branch, I think the stent strut, if you try to push the bigger balloon, if it's not going, this can create a problems. Availability of coronary snare is must in every cath lab. Inspecting the wires and balloons for any weak points is necessary before use. Then there is a dislodged stent. That was a 69-year-old male came with a unstable angina. Angiography shows diffuse RCA proximal to mid lesion, angulated RCA, some calcium and the fibrosis. We dilated the RCA, tried to took a 3/48 stent, but it was not crossing. We tried to pull. I think while pulling and pushing, the stent got dislodged in the proximal RCA, outside the RCA, and the balloon came out. Wire was inside only. We were lucky enough so that we could put a 1.5 balloon, 12 balloon, dilated the stent, took a 2.5, 12, dilated the stent completely. From ostium to proximal lesion was dilated, then they took a 3/15 balloon and dilated the stent. And afterwards, we had to cover it with a second stent in the mid to distal RCA. And distal edge dissection, again, we had to put a third stent and completed the plastic. We were lucky enough that the wire was inside, so we could took a smaller balloons through the stent and inflated, and got the result. Inflating a catheter balloon distal to the undeployed stent, dislodged stent can be twirling 2 wires around the stent. Snare is important. We can crush the stent and plus another stent across it, or stent reposition and expansion. That's what we did in our case. Wire was there, so that we pushed the smaller balloons and tried to inflate the stent, and we could inflate it and complete the plastic. So again, that was a angulated lesion, calcified lesion. Good lesion preparation is essential, especially in calcified vessels, to avoid difficulty in negotiation of stent. When found difficult, cross mother-child catheter is important to push the stents. When stent dislodgement happened, gradual dilatation of stent to be ensured with approximate size balloons, and imaging can help. Last but important complication, this was a very heavily calcified LED. We decided to do a rota, and it got entrapped in middle to distal LED. We tried to use cross the wires, filter FC, stiff concave wire, so that we'll put wires across the rota bar and put a balloon and dilate the proximal part, which will be able to retrieve the rota bar. But we were not successful in passing the wires. And again, at high speed, we tried to reactivate the bar, and it got reactivated, moved it proximally, and we could remove the bar. And then we completed the procedure with a smaller and larger balloon dilatations. This was the entrap bar at distal left anterior-descending artery and rescued by balloon inflation at the proximal stenotic lesion. Burr was entrapped in the mid-LED lesion. We could pass the filter FC wire, so proximal, whatever the calcified lesion was there, we dilated with a high pressure at 14, and with that help we could remove the entrapped burr. Mechanisms for such complication or insufficient packing motion or a high-speed rota burr. Several bailout techniques, as I showed: simple manual traction, passing another guide wire, balloon dilatation. And you can cut the rota burr outside and put a snare or a child catheter to facilitate the successful retrieval. And gentle packing motion with shorter runs of ablation may prevent such complications. Stiffer wire may be used to straighten the lesion. I think as we are doing more and more complex cases, we are going to land up with these complications. And I think from these mistakes we learn. Your last mistake is your best teacher. And learn from the mistakes of the others. You can't live long enough to make them all yourself. Thank you very much.